So welcome to our second speaker as part of our series in Conversations in Health. My longtime colleague, Christy Martin. Well, now that we've had all these conversations, I remember how many people we have in common. But we have a terrific speaker tonight. Sometimes our speakers have really important things to say, but they aren't necessarily like news straight from the headlines. Tonight is different. There was a major press conference yesterday at the White House talking about prescription drug pricing, and I don't know if I'd say historic, but at least an unprecedented agreement between the administration and Pfizer, and we'll have somebody here who actually understands and can help us navigate what's happening right now. But these issues around prescription drug pricing that Christy has spent her recent career on are really front and center in public policy. So anyway, this will be a really exciting evening. So Christy, let's start at the beginning. So tell us a little bit about where you were, where you grew up, and then help us guide from that point through coming to college, because almost everybody here, they're either in college or in the graduate programs, but they're thinking about where to go next in life. But why don't you start us at the beginning and tell me a little bit about when you got interested in health and health
Sure.
policy.
So I feel like the people who just named a state are probably going to identify more with where I grew up. So I'm originally from Kentucky. I grew up in a place called Beech Grove. So my town had less than 200 people. I'm from a family of farmers. My grandfather owned a farm and was a farmer. My mom was a public school teacher. My dad was an aluminum worker. He was actually a welder. And, very blue collar, very rural area. My mom lived next door to my grandparents pretty much for her entire life. Still lives where she's always been. And so, very modest growing up. The high school I went to was 20 miles, and my elementary school was 20 miles from where we lived. My mom was the teacher in the high school. And for the most part, not anything out of the ordinary. I think, I got interested in health because when I was 11, my brothers and I came home from school, and my grandparents were waiting for us at the kitchen table and told us that my dad had stage 4 cancer. And, telling that to 11-year-old, I had no clue. My brothers were a little bit older than me, and we're just okay, sure. And so for the next year, my dad was in treatment. At one point, they were like, he's cured, and then he was back in treatment. And my parents ended up moving to Louisville, which was about 2 hours away, for 3 months for him to go into a clinical trial. And on Christmas Eve, they decided the clinical trial wasn't working. The doctors did. They sent him home, and they said, that's it. We're done. And so he passed away about 3 months later. And my mom became a single mom. She raised us, and she did an amazing job. She raised us to be very resilient, independent people. And she really wanted us to think about how we can make the world a better place. I mean, they were people who really believed in, being in a union and making sure that, you went to church and you really thought about, how could you get back to your community? How could you be part of your community? And, my dad being sick and watching all the people in our community kind of take care of us and take care of my dad and take care of my mom and come together. And then my parents could move to Louisville for 3 months and leave us at home, and people could take care of us, and we weren't in debt. My dad's union insurance paid for it all, and we didn't have to worry about it. And at the time, it didn't seem like a big deal, but as you get a little bit older, you kind of realize that's not the case. You'd see other friends, their parents got cancer, and they were struggling, and they were having trouble. And then, so I went off to college.
Where?
University of Kentucky.
Of course.
Yes, I'm very proud Wildcat.
Yes.
I love Kentucky basketball. We won't talk about football. It's very sad. But went off to University of Kentucky and knew I wanted to be in healthcare, knew I wanted to work in healthcare. So I ended up majoring in health communications and just really didn't know exactly what I wanted to do, but knew that like wanted to be in the health field. And so my thoughts were I wanted to help people understand healthcare. I wanted to help communicate about how to be healthier, how to communicate healthy messages, how to make sure people are getting cancer screenings.
Right.
So like cancer was a big piece of it, healthcare was a big piece of it. And, really loved my time at the University of Kentucky, had a really great experience. And I was on a dual track. So I was doing my bachelor's and I was accelerated, and then I started my master's degree, and I was set to finish around when I was 21. And I was like, well, I'll just start a PhD. And my advisors my bachelor advisor and my graduate student advisor were like, no, you need to leave. They were like, you need to go do something and then decide that. You need to go have an experience because you can't just be in school forever. But in my head, I was like, I can be in school forever.
You're thinking that's not such a bad alternative.
Yes, I was like, why would I leave? This is great. I'm having a great time.
There may be some people in this room who think that as well.
I was a research assistant. I was working on a project about antimicrobial resistance, which I thought was great.
Bad, but interesting.
Yes,
exactly.
But it was about educating parents on like when you should get an antibiotic and when you shouldn't get an antibiotic. And this was like 20-something years ago, which is still a problem we have. But I was I was really enjoying it. I felt like I was doing it, interesting stuff. So I was like, okay, I'll do what you say. So they had found, there was a fellowship at the National Institutes of Health, specifically the National Cancer Institute, called the Health Communications Fellowship. And they're like, we've had several students to do this. They've all had a great experience. It's a 6-month fellowship that you can extend to a year. Apply for it and go. And I was like, okay, sure, happy to. So I applied and I got in, and I moved to D.C. I'd never lived anywhere else, just in Kentucky. My mom's like, where are you moving to? I'd never been to Washington, D.C., ever.
Wow.
So we came up, we found an apartment in Bethesda. I moved. I think my mom at one point thought I was like gonna just move back immediately. But I just fell in love with DC. And so I was in the fellowship for 6 months. I ended up extending.
Just 6 months, okay.
Well, I extended.
Okay.
And then I decided that maybe PhD wasn't for me. I think being in that setting of the Cancer Institute made me realize academia might not be the right place for me to be. That was a very academia-like setting, very competitive. People very much like thinking through, how do I get attention to my work? How do I compete for money? Which is very much what you have to do when you're in a research setting in an academic institution. And so I was like, okay, maybe I don't go for a PhD. So I started applying for jobs here in DC, and I was applying for jobs that were health communication, health marketing, and I ended up getting a job at Easter Seals Government Affairs shop.
So let me ask, I just want to, because I think this will be fascinating. Before when you went to college, there was already a group at Kentucky that was thinking about health communications as a track unto itself.
Yes.
So that's fascinating.
It was one of the top programs in health communication. So I think we were ranked at the time when I was there, we were ranked number 3 in the country.
Yeah, makes sense.
Penn is one of the top schools. I think there's a UCF, I think is another top school. So there's a few that's like their specialty is health communication.
So you were really ready for this fellowship, but
Yeah.
you decided you wanted to stay, but you fell in love with DC.
I fell in love with DC.
So-
I felt like it was a city, but not too big.
So tell us about the Easter Seals.
So yeah, started working in this government affairs shop. I felt like my research skills, I was doing qualitative research, and I felt like those research skills just translated really well into policy analysis. And then that job led to, I think, probably one of the most important jobs I had, and that really unlocked like the rest of my career and set me on the trajectory that I am today. And that was, I applied for a policy analyst job at the American Cancer Society. And that job ended up being in 2007. So it was right before Obama got elected. And that's when Massachusetts was going through their healthcare reform effort under Governor Romney. It's when Governor Schwarzenegger was trying very hard to get his healthcare reform effort off the ground. And I was hired as the policy analyst to do state health insurance regulation.
So, could you say a word about what a government relations shop looks like, both at Easter Seals, which would be smaller, but ACS is a very large
Yes.
operation.
So at Easter Seals, it's a very different type of entity because they are a service organization. And so they do a lot of lobbying. They do a lot of more traditional government affairs in terms of they work on the Americans with Disabilities Act. They work on some HHS stuff like Administration for Community Living, appropriations and things like that. But they're really more focused on transportation issues. They're more focused on their service delivery aspects. They do a ton of respite care in the communities. And so
It focuses on people with disabilities.
people with disabilities. And they've been around for a very long time, but they have a very, their focus is more on how do they support their entities within the communities and within the states. And so it is less about how do they engage maybe necessarily here in DC, but how do they make sure that they're getting the right attention to support what could help essentially their affiliates in the states and in local communities. American Cancer Society is a well-oiled machine. And so whereas Easter Seals is a very small team, so where you would have policy and maybe the lobbyist is all kind of one team, American Cancer Society is set up that there's a policy team, there's a federal lobbying team, there's a state lobbying team, there's a grassroots team. So there's individual teams because they had the resources and capability to do that. So I was on the policy team. And I supported the state lobbying team, the grassroots team, and the federal lobbying team. And so that's where I met people like Karen Politz, who is probably one of the foremost experts on health insurance, I would say, in the country. And probably one of the most important people when it came down to actually drafting the Affordable Care Act and some of the ideas that came into the Affordable Care Act. And it was such an amazing experience. I was there at the beginning of the Affordable Care Act getting off the ground. I was there when Obama got elected and the idea started forming about we can do healthcare reform, we can do insurance reform. And part of what I was able to do at the time, and I think that part of it was being in the right place and having the right set of issues and being given some autonomy to work on some issues that maybe other people didn't want to work on, but they were the issues that became the issues that were important. Our call center, the American Cancer Society's call center, was based in Texas, and they had started a health insurance assistance service. So when people were having problems with their health insurance, you'd call this specialized team, and they would help you find financial resources. They would help you find resources so you could appeal a claim. So if your service got denied by your insurance company, they would help you figure out somebody that could actually walk you through how to appeal the claim and try to get the service paid for. So I started working with them. Karen had set up a system. She was actually at Georgetown at the time.
She was at Georgetown.
She was at the Center for Health Insurance Reform at the time. She was working with the Cancer Society. They'd set up a system. She had trained the whole team, and her team at Georgetown had worked really closely with them. And they had started collecting all these stories. And so then I was working with Karen, and what we started to do was mine the stories.
And so Karen was based at the Center on Health Insurance Reform as part of the McCourt School of Public Policy.
Yeah.
So,
and that led to the Cancer Society was probably one of the first that really started to use storytelling integrated into policy and integrated into in a more of a data way of how we were doing our lobbying and how we were doing some of our advocacy efforts. We ended up partnering with the Kaiser Family Foundation. We produced these reports that basically took the data from the call center about what types of problems people were having. We paired them with the stories, and then we wrapped the policy around them to say, here's why the policy is broken down, and here's how it plays out in somebody's life. And then we had these reports that come out. They were They were on like morning talk shows, morning news shows. Katie Couric was on CBS Evening News at the time. They were on her show. And that was just really an amazing experience. And like, you know, I think we really felt like we were part of something. My co-author was Karen Schwartz. She's now at Pharma, which is bizarre now that I work on prescription drugs and she works on prescription drugs, and
From somewhat different perspectives.
we're on different sides of the table now, but we're still friends and we're still colleagues in a sense. But she was my co-author on those. So then once I left the Cancer Society, I took a short turn into the Government Accountability Office and thought I wanted to do that type of work as an auditor, and then decided, nope, that wasn't for me. And then Karen ended up at the Office of Consumer Information and Insurance Oversight, which was the office that was implementing the Affordable Care Act. And so I called her and I was like, can I help you? And she's like, yes, bring your friends. And so a group of us went in to start implementing the Affordable Care Act. I was the second group hired. So I landed in August of 2010 into HHS and began implementing the Affordable Care Act. And so I started on the Consumer Assistance Program, which was based off the Health Insurance Assistance Service from the Cancer Society, that project. So we set up these state grants, worked with the states to set these up in every single state in the United States, very similar to the Health Insurance Assistance Service. And then we moved on. The Office of Personnel Management needed help setting up the multi-state plan program. So Karen was friends with John O'Brien, who was over at the Office of Personnel Management at the time, and he said he needed help. So Karen's like, I have a group of people. I was one of the people on that team. So we went over to set up that program. We got that program off the ground. And then Kevin Thurm, who was the former Deputy Secretary for Donna Shalala during the Clinton administration, talked to Karen. He's like, Mina Seshamani, who was head of the Office of Health Reform, needs some help. And Karen's like, I have somebody for you. So I ended up going to the Office of Health Reform to help set up the Women's Preventive Services Initiative and some other things. So then I became kind of known for being a person who could just come in and help to set things up, help to get things going, keep things on track, new programs.
And you definitely had that reputation. When did you decide that was the way in which you felt like you were making the most impact? Because you've been working on sort of the advocacy side and the communication side, but you definitely moved to the person who solves things, put teams together, makes the trains run.
Yeah, I think it really started off with the Cancer Society. I think that one of it was I just felt it played into my skill set really well, and I felt confident in doing it. I'm an incredibly organized person.
Yes.
And I'm a very detail-oriented person. So the fact of like thinking through a project plan, thinking through a timeline, thinking through a budget, all those components that you need to do in order to set a program up, that's just comes pretty naturally, and I like it. I enjoy it. So, and then when you put policy in with it, it's just that's the problem-solving aspect of it. And so for me, it just kind of came easy, and it just clicked.
Okay.
And I think that's part of what makes, I think with a lot of careers, you have to find what makes it your passion. You have to find that you're there for the right reasons. And if you ever feel like it's work, you'll have bad days. It happens. But if you ever like day in and day out, I'm not enjoying this, then you know that it's not right. But for the most part, like that's the part I love. I love being able to work through the policy, build the policy, and then wait for the day I can go into government and see it through, all the way through.
And you got a chance to do that.
I did. So when I left Office of Health Reform at the end of 2016, I was lucky enough to go to Henry Waxman's consulting firm.
Henry Waxman?
Henry Waxman is the former congressman from California. He served in Congress for 40 years. If you pretty much look up any health law between pretty much the late 70s through 2015, chances are his name's on it. And his staff wrote it. So, Hatch-Waxman Act, Orphan Drug Act, Medicare Drug Rebate Program, Affordable Care Act, you name it, he probably did it. He was responsible for most of the Medicaid expansions during the 80s, 340B, which we can debate that program all day long.
Which is
Medicaid,
1 cent.
yeah, 340B drug discount program. So it's a program that requires manufacturers to sell drugs discounted to safety net hospitals and community health centers.
Thank you. Sorry, I don't mean
Yeah.
to interrupt, but we
Nope,
the
that's
world is
good.
filled with, we have folks here who have more and less knowledge of the
So-
super complicated system we've created.
So when I was at the end of Office of Health Reform, Gilead, the drug company, had just come out with Sovaldi, which was one of the hepatitis C cures, the first one. And people were a little sticker shocked when it came out. It was about $80,000, but it was a cure. And just to give you a sense, if somebody gets hepatitis C and it does not get treated, they most likely will have a liver transplant at some point. I mean, it's pretty serious. So, Medicaid programs were very worried about how do they afford this. Prisons and jails were very worried about how did they afford it. So a lot of public systems were like, this is so expensive. Private insurance companies were like, this is a really expensive drug. But the thing was, it's a cure. 12 weeks, that's it. So, and then there was 3 other products that came out. Gilead had a couple of them, and then Merck, I think, had one, and then there was another company. And so drug pricing really started to kick up as like, is this a fair price? Are drugs affordable? Should we be doing something? And we worked on it a little bit at the end of the Obama administration, but then I ended up going to work with Henry and Bill Core, who was, during the Obama administration, was Deputy Secretary for Health and Human Services and had worked for Henry during the 80s on Hatch-Waxman and Orphan Drug Act. So we started working on drug pricing. We were being funded by Commonwealth Fund and Arnold Ventures and West Health, which are three philanthropies. They were working in the space. And we did a series of reports. And really we're focused on Medicare negotiation, but some other efforts as well, patent reform, things like that. And just kind of started to think through what could negotiation look like. Most efforts to this point had been Medicare will negotiate drug pricing and, had just been one line in legislation. But the problem with that was the Congressional Budget Office, which is responsible for scoring legislation and telling Congress how much is this thing going to cost or save the government, would say, well, we can't score that because there's no detail. We can't score it. So we were challenged with, well, how do you think about a policy Congressional Budget Office could score? So we went to work trying to answer that question. And that eventually led to H.R. 3, which was introduced in Congress in 2018, passed the House, and then at some point in time became part of the Inflation Reduction Act, which passed in 2022. And then right before that, I ended up going back to Centers for Medicare and Medicaid Services as the Chief of Staff for Medicare in anticipation it was going to pass.
So could you say a word about what a chief of staff does in center? I mean, this is a large agency,
Yes.
even within HHS. So
Yeah, so, it's a little bit dependent on who you work for, but generally they're the person who makes sure that all the functions within the entity, and I was Center for Medicare, so thinking about the operations, the policy, all of that is staying on track. Keeping eyes on all the pieces at all times for the principal. So Center for Medicare Director was Dr. Meena Seshamani, and being their right-hand person, making sure that if there was a fire, that you knew how to put it out or you could see it coming. Thinking through, what is the cadence of things that are coming. Also helping with, one of the things I was helping Nina do was set up her front office. I was also helping with her external affairs in terms of, we ended up hiring people, but thinking through what does her external affairs strategy look like, what types of speaking events does she want to start trying to do, what types of engagement does she want to start to do, how does she want to have external entities engage with the center while she's there. So not just her as the center director, but the center as a whole. And so, I was also doing a lot of special projects. So one of the special projects that I did was, we ended up doing a demonstration for over-the-counter COVID-19 test in the Medicare program, because Congress authorized COVID-19 tests to be paid for by private insurance and Medicaid, but for some reason they left out Medicare. So we ended up doing a demo to make sure we had parity. And so I ran that special project. So I was doing a lot of that, a lot of project management, and then coordinating with other chiefs of staff across the other centers and offices, as well as coordinating with the chief of staff, and then also working across the Department of Health and Human Services and then the White House. A lot of coordinating, a lot of facilitating. I feel
So
like
being organized was a very helpful
being
quality.
organized and being calm. I think that's a big part of it.
So how did you feel when you saw the IRA provisions on Medicare to go? Did you feel like it reflected what you'd hoped for, or did it?
Yeah, I was really proud of the trajectory of it. With any piece of legislation, there's always give and take.
Right.
Nothing is perfect. I think, there's the adage, don't let perfect be enemy of good enough. It was good enough. And so, I feel like it's just like the Affordable Care Act. There's always going to be things that you wish
Right.
get fixed along the way, get cleaned up along the way. But people had wanted to pass Medicare negotiation for 40 years, and it got done. So you can't be upset about anything.
My first job on the Hill in 1989, working for David Pryor, we did prescription drug price hearings. We recommended all these great negotiating strategies that went nowhere. The only thing, we did get discounts for the Medicaid program. That was our big accomplishment, but nothing like what you guys got done. So maybe just help us understand, okay, the IRA passes, this thing that you had worked on proposing now is law, and you're the chief of staff at Medicare. So what does it mean to be then making it happen, implementing it?
So it passed in August of 2022. By August of 2023, we had several milestones we had to hit. So there were several provisions in that first year. We had to implement one by October of 2023. That was the first one. We had to implement two more by January. We had to implement another one by April, another one by June, and then the biggest one was we had to announce the first set of drugs to be negotiated by August. So to say it was a sprint was an understatement. We had to be able to issue guidance by April, along with some other things, and we had to hire 200 people.
And you were in charge of that.
Yes,
And did you guys hit the deadlines?
we did every single deadline.
So do you feel satisfied? I mean, that's quite an
Yeah.
accomplishment.
Yeah, we were. It was very funny because we did not miss a single deadline the entire time Mina and I were there, and we were very proud that we did not miss a deadline, and we were early on most of them. So it's funny because that's the thing. Probably when you hear us talk about it, you definitely hear us, and even the team. We'll get into it, I'm sure, but
Sure.
the negotiation guidance came out yesterday, September 30th.
When you say the team, you're still referring to the civil servants who are working.
The civil
on
servants that we hired are still there, and they're amazing. They're brilliant people, and September 30th was our target date last year to get the guidance out, and they got it out this year on September 30th, so I know that was their target date. So, I'm very proud of them because I know that that's what their target date was.
So I'm going to ask you a question, just because we had this sort of timely event yesterday, but then we'll turn it over to class. I mean, so yesterday, it seemed to me, as those of you I'm sure who are tracking this know, the president hosted the CEO of Pfizer, and they announced an agreement that it's not entirely clear what all the provisions are, the dimensions of it, but I thought maybe you could help us understand a little bit about what was announced yesterday, what you think is going to happen, what maybe is not going to happen as a result of this. It really does seem the Trump administration has moved from working through a very precise law for negotiating to a really different model, right?
Mm-hmm.
That uses this sort of call for most favored nation policy for sort of evening the prices you Americans pay with other countries. You got tariffs, which have been moving in different directions, and we're just actually this afternoon they announced they were putting the tariffs on pharma companies on hold, and then there's this push for this other tool of like direct-to-consumer pricing, which may or may not result in reductions, and then the guidance that your colleagues
Mm-hmm.
put out. So you got those 4 tools all working for at least 2 different purposes, right? One is to reduce drug prices, but the other is to encourage more domestic manufacturing.
Right. Mm-hmm.
And it's kind of a jumble, right?
It is.
So if you could help us maybe just like your take on what happened and how we should think about it, or how we should start to think about it.
I think maybe it helps to kind of set the stage and go back to the first Trump administration. So in the first Trump administration, they tried several things that actually never got implemented. So they tried most favored nation before, and they got sued because they didn't go through the right administrative procedures. So it never got off the ground. So when they came back in this time, I think they were like, okay, well, we're going to try it again, but we're going to try it a different way. And earlier this year, they started talking about the tariffs. They started talking about most favored nation. There was the executive orders that came out. And you started to see stuff start to form. You also, at the same time, started to see some of the drug companies, Bristol Myers Squibb was one of them, but there was a couple of others, that started on their own doing the direct-to-consumer sales platforms. And so direct-to-consumer sales is not a new model. They've been around for a while. Eli Lilly actually has been doing it for quite some time. You've seen it happening, Hers.com, Hims.com, Ro. I'm sure you see them on the telephone and whenever you're on apps daily. So it's not a new model, but it's a growing model. It's a very profitable model. And so you're seeing this happen organically in the market. And so what the Trump administration, they're seeing this happen. They're seeing it grow. And so they're using that, I think, and taking it to their advantage. And so earlier this summer, they sent letters to 17 pharmaceutical CEOs. Pfizer was one of them. You saw announcements being made last month that some of the companies had raised their list prices in the UK for certain products, which was part of the CEO letters to raise their prices in foreign countries. But when you raise list prices, nobody pays a list price. Not in the US, not in other countries. It's all confidential pricing. So nobody's paying that.
Just maybe 2 more sentences. So list prices means the pricing you tell the public.
Yeah.
But every buyer has their own
Generally,
private, personal.
Actually has a
individual.
confidential net price that is like negotiated between the payer. So in the UK, it would be like their National Health Service, NICE, whatever. In Germany, same thing. They have a negotiated price, and then they may have a list price on top of that. And so Pfizer had not made any concessions. They had not announced anything yet. And so they were the last to the table. And so that's where the announcement came yesterday. But other companies you'd started to see them kind of fall in line, as part of these. And so the announcement yesterday was interesting, I think, for 2 reasons. One, Pfizer announced with the Trump administration in the middle of the day, which for a publicly traded company to make that type of announcement at the White House with an elected official was unusual. And if you watch, I typically watch the stock market to kind of get a sense of what everything means when things are happening, you know, whether it's health insurance, prescription drugs, because these are all publicly traded companies. And you're seeing the press conference go on, and you see stock prices go up. So that's an indication. Investors think this is a good plan and a good idea for the pharmaceutical industry. So that kind of gives you an indication, probably not going to hurt their profits. Another interesting thing about it is the way they talked about it. They talked about the discounting is, it was 4 drugs that they said were going to be included. Xeljanz was probably the only one most people recognize because that's the one you might see on TV.
Right, it's advertised.
Yeah, the other 3, not very commonly used drugs. They were discounts off of list. So that means it's not clear if they're actually lower prices than maybe what we're getting through our insurance, or maybe what Medicare is paying, or what Medicaid is paying. It's very unclear what that price might be. And they didn't announce what the price was going to be to consumers through the strict consumer sale. They just said X% off of list, 85% off a list, 50% off a list, but they didn't give us a price. And then they announced it would be part of this TrumpRx.gov platform, which is not even going to launch until January. So we won't even know for several months of how this is all, what this is going to look like, how would it work, who's it available to. Is it for people who have health insurance or Medicare or Medicaid? Is it only for people who are uninsured, who's eligible? None of the details were there. And that's the stuff that actually is important. That's how you evaluate policy, is like you need the details. And so I think as of today, it's really hard to make sense of what it all is and how will it actually lower pricing for people and who will it lower prices for. And so, and if you go to TrumpRx.gov, it doesn't go to anything. There's not even a holding site. It's just nothing. So I'm not very optimistic that it's going to lower prices for a vast majority of people. Maybe it'll help some people. The other thing I will note, Pfizer is also currently today in negotiation with the Medicare program for 2 drugs, which I also think that is interesting that they were doing this deal with the White House while they are currently negotiating with the Medicare program for 2 drugs.
And is 2 drugs a large number of drugs or a small number of drugs for a company of its size?
So Medicare only negotiated 10 drugs last year. They're negotiating 15. There's not very many companies that have more than 1 drug at a time negotiated. So to have 2 is pretty.
The stakes are high.
The stakes are high. That's a lot for a company to be negotiating at one time with the Medicare program.
Well, I told you we would have somebody who'd be able to guide us through but I guess one thought before I'm going to ask Kristen, I guess, to start us off. But one thing to think about policy, I mean, and obviously policy is just one way in which you can engage in health, is that what's announced is not necessarily what's going to happen. And so part of your tracking these developments over time, just the way that you articulated, is to try to understand what people are saying, but also, just as importantly, what's not being said. And that lets you think about what real-world impact is. So now we'll turn it over. So, Kristen, you want to kick us off?
Yes, I'd love to. So a question that I came up with, actually, while you were sharing was you brought up something about storytelling, which I thought was a really cool narrative because I'm a healthcare management major and I'm minoring in art. So there's a lot of this like storytelling aspect that I'm trying to convey in my future career. And so I guess, like, in what ways have you kind of employed that storytelling narrative like you did in the American Cancer Society? Because you said that kind of informed the data reports and it kind of helped to humanize the data, which then informed and helped to push policy. And I'm wondering, I guess, because you also have a financial background working at Arnold Ventures, how you've kind of taken this storytelling narrative to really help you shape and think about policy.
I think sometimes policy is really abstract or conceptual, and people have a hard time when you're talking about it wrapping their heads around what it means or what you're trying to convey. And so the storytelling can make it more tangible. And so when you're trying to tell people about, for example, prior auth of prescription drugs, they may gloss over and like not pay attention. But if you tell them that there is a patient who's a cancer patient, and every 3 months they have to go through a process that they have to be on the phone with their insurance company for 4 hours to get their drug approved for their cancer treatment, that actually means something, right? You're quantifying what it means for that person to go through that policy that is broken down, and that we need to fix that policy. And so the storytelling can really, I think, give a better sense of like how that policy actually applies in someone's life, and articulate like why it doesn't work. And we talk about a lot when I, all through my career I've talked about policy only works if it makes it to the last mile. If it doesn't make it to the last mile, it doesn't work. And so as you guys are working in policy, as you're working in healthcare, think about that. If the policy doesn't make it to the person, if the policy doesn't make it to the patient, if the policy doesn't make it to the provider, the person who's at the end of the line, if it doesn't work for them, that's not good policy. So you have to think about how it works all the way through to the end. And I think that's the point with the Trump RX. Like, there's not enough detail to even think about, like, what's that person's experience like when they go to trumprx.gov? Like, is it going to be a pleasant experience? Is it going to be the drugs that they need? Is it going to be the price point that they can afford? Is it going to be frustrating? Is it going to be simple to use? How are they going to be able to select drugs? Is it going to be administratively complex? This is how you kind of think through the storytelling piece, but also just to humanize policy.
So, Sophia?
Yeah. Let me pick this question. Okay. This is one of the ones we talked about ahead of time. Given that a majority of Medicare beneficiaries are older white women, how should policymakers account for demographic realities and accessibility while ensuring equity for more diverse populations who are also affected by high drug costs?
So the Medicare demographics and population reflect the current population of the U.S. for the most part. And so the good thing about that is we can see what's going to happen in the future because we can see the population aging, right? And so we know what the demographics are going to look like in 10 years in the Medicare program. And I think we also have to think about like racial, ethnic, cultural diversity, but we also need to think about rural aspects as well, technology, because there's a lot of disparities in those fields, in those areas as well. And it is sometimes really hard with the Medicare program to think through those things. Medicare accounts for one of every $5 in the U.S. healthcare system, 67 million people in total. It is 98% of the providers in the U.S. And there are states like Vermont where there's only one Medicare Advantage insurance plan. So if you want Medicare Advantage, you only have one option. There are places that have pharmacy deserts in the U.S. And so I think that there's a lot that Congress can do and policymakers can do to think through how do you, one, make sure that Medicare is delivering on the promises because it is a benefit. People pay into Medicare and they're supposed to get that benefit when they turn 65. And so they can think about what is that benefit and are they delivering that benefit and start to think through, how can they shore up the Medicare program. One thing that I think has been a constant, and John, probably you can say this, the solvency of the Medicare program is a constant issue. Yeah. And so that's a struggle as well. How do we maintain to ensure that the Medicare program is solvent while also making sure we're providing all the benefits it needs to provide to deliver to all the people we need to deliver to? One of the things that I think the Medicare program has done incredibly well over the last few years in thinking about equity in particular is, and I think this gets to some of the solvency issues and being more flexible and being more nimble, they've been doing payment to encourage community health workers. So getting community health workers into the program, thinking about how do we how does the Medicare program pay for social determinants of health? You know, really trying to think about how do they meet the needs of the Medicare program and the Medicare beneficiaries in a way that stretches that Medicare dollar, but does it in a way that can get to the equity issues that we need to get to. And so it's a complicated issue. And I think, unfortunately, it's at a tension with some of the financial issues that Medicare is facing.
And for those of you who want to look more at the solvency issue, if you look at the optional reading for this week that had the backgrounds or primer on Medicare, the challenge is that you are balancing a defined revenue source through taxes and a set of benefits that are defined by the federal government. And every decision to open up the availability of certain kinds of services or certain kind of providers, it has a cost. Sometimes those costs are offset by other reductions, sometimes they aren't, and that's the trade-off. But that's terrific. So I'm gonna, Sarah? Oh, I'm sorry. I thought I was trying, thank you. Please.
So, I thought it was really interesting how you were talking about how you became known as the person to like help out and start something up. And I thought it was also cool how you said it really clicked with your like strengths in organization and problem solving. And so I just want to ask for like students starting out, what strategies do you recommend for like discovering their own niche or a certain aspect in like healthcare careers or healthcare policy?
Yeah, I mean, I think it's be true to yourself. Don't try to fit something that doesn't feel right. You know, I think that if I've always been a tightly wound person, like a very tightly wound person.
But a nice, tightly wound person.
Yes. And I think if it's funny, like, I've always been a very organized person, and I've always been a person who works, like, I don't want to do anything and not do it well. And so when I was in high school, I went to a very small high school. I graduated with 106 people, and it was in the whole county. And so when I was in high school, my senior year, they decided not to teach calculus. And I was upset because I really wanted to take calculus just because I liked math. And so the calculus teacher, the math teacher, said, well, I'll teach it if you guys want to take it at 7 a.m. So myself and 4 of my friends said, we'll do it. So we took it 5 days a week for the entire year of our senior year, 7 a.m. And like, that's the stuff to pay attention to. Like when you're thinking about like, what are your strengths? Like the fact that I would be like, yep, I'll do that. You know, that's just like, I have a commitment to things that is, you know, that's one of the things I'll just hunker down and do something. So I think that's one of it. I think the other thing to think through is don't be afraid to get into something. You know, I tell people all the time whenever I'm talking about policy, people are like, oh, this is so complicated. I don't know this issue at all. You can learn policy. Learning an issue, 6 months, you can talk about it. Don't worry about knowing the issue. Think about building the skill. You know, being able to read through what you need to read through, being able to decipher break the issue down, being able to brief someone. Think about what the skills are that you can learn. But, you know, don't worry so much about being intimidated about what you need to know or what you need to do. Just lean into what your strengths are and what your personality fits well. I think the other thing too about being nice, I told this whenever we were hiring people. I think I've told you this before. We hired a bunch of people, and I like screened and like did all the interview, like I did like pre-interviews and collected resumes. And I told people, I was like, listen, we have 3 criteria. 1, you have to be nice, because like we want to be around you, and we're going to be around you a lot. So you have to be nice. 2, you have to be here for the right reasons. If you're coming in, you've got to want to do the work. And like negotiation, if you're working on negotiation, if you're working on the extra help program, if you're working on the Part D redesign, if you're working on the $2,000 out-of-pocket cap, all the stuff in the Inflation Reduction Act we were working on, that has to be what you're committed to. And so be here for that reason. Be here because you truly believe what we're doing is the right thing to do. And the third was be flexible. Because you're going to get hired for a job, but the thing is, there's a lot of work to do. And so if somebody says, like, listen, I need you to pitch in over here, the answer is always going to be yes. And I think that be flexible part and be nice part applies to everything. Because you never know when opportunity is going to come. By just being like, if somebody's like, hey, can you help me out? Just saying yes to things. I said yes to a lot of things that I was just like, sure, what? I'll do that. And it's always worked out. And you'll always have gut instinct about if things don't feel right. And if your gut is like, then say no. But for the most part, be open. Be open to opportunity.
For those of you who may be looking for work now or soon, this is great advice from somebody who's hired a lot of people.
I've hired a lot of people. Yeah.
So I think I've got Bridget
Yes.
as the, thank you.
Thank you so much for speaking with us today. I did have a question that you kind of touched on a little bit, but how do you see policies like the Inflation Reduction Act affecting healthcare equity and access, like overall?
So the way that the whole, like all the Medicare provisions were structured as a package deliberately. So negotiation was meant to pay for the other stuff. So if you think about negotiation was the saver, and then that money was used to do the things to enrich the benefit. And so that included expanding the Extra Help program. So the Extra Help program is a program for low-income individuals that pays their co-pays and their premiums for their Part D prescription drug coverage in Medicare. We also did the $35 insulin cap. We did the no-cost vaccines, the $2,000 out-of-pocket cap in Part D, and we did a Part D redesign, which restructured the Part D benefit to get rid of some perverse incentives that were causing the Part D plans to push up spending. And so if you think about that, the whole point of all those pieces together was to try to make drugs more affordable to people. I mean, the $2,000 out-of-pocket cap alone, there are people in Medicare who are paying tens of thousands of dollars a year out of pocket for drugs. So having that we were hearing, there was one woman we heard from in Missouri, the $35 insulin copay for her in the first year meant that she was paying her mortgage. Just having that $35 insulin copay cap go in meant she was going to pay her mortgage on time. And that may seem insignificant, $35 copay cap, but for her, that was really a big deal. And then the $2,000 out-of-pocket cap, for some people, they were hitting it in the first month in January. So if you think about it, they were paying $2,000 in January, that meant they were probably paying $24,000 in the year at least. So, I think that trying to make things more affordable for folks across the board. And then the Extra Help program in particular, the Extra Help program expanding meant that more people were able to afford prescription drug coverage. So people maybe who couldn't get prescription drug coverage before were going to be able to get coverage. So they may have been going without retail drugs. And so that enabled them to get on. So, there were pieces like that, and it was all meant to make sure that we could extend the program benefits as far as possible and make sure people were getting on it. The other thing, too, about the negotiation program, the drugs that were selected the first year, most of the drugs selected were chronic condition drugs, cardiovascular, diabetes related. And then in the second year, we're seeing kidney disease related. The first year there was one or two kidney disease related, cardiovascular, diabetes. If you look at the profile for Medicare, the people who are typically taking those drugs are people of color. So by negotiating those drugs and hopefully making those drugs more affordable, and hopefully pushing down cost sharing on those drugs, means that maybe people are not skipping doses. They're not cutting pills in half. They're not doing the things that we're hearing that people were doing. So all in all, when you take all that into account in totality, the goal is that we're making their experience better, and we're making sure they're getting the care they need. And then hopefully, if they're taking their drugs, they're affording their drugs, that means they're not going to the emergency room. They're not having hospitalizations, which is good for Medicare and good for taxpayers too. So that's kind of the big picture of it all, is that it gets back to improving everybody's life.
All right, so I'm happy to open up to the rest of the class. Anybody have questions? How if I start right to left? So, Lou?
Hi. Thank you again so much for coming. I have a two-part question. The first part is, I'm curious, kind of in the health communications background, how you've seen those communication skills play a role in policy, and in like getting ideas across. And then the second piece is a little broader, but advice you have for someone interested in being a part of insurance reform.
So I think, communications is really handy. So I was a double major. So I was an advertising major, and then I was doing the health communications research as well. And both of those combined, being able to think through how to make things short and pithy, that's helpful. But then also thinking through, especially working as chief of staff in particular, but also working in the storytelling space and working in the advocacy space about, how do you craft compelling messages? Because you can just turn a phrase and go from being unpersuasive to persuasive. I think even like I was talking today, I'm writing a health affairs blog with a colleague about the negotiation guidance that came out yesterday. And it's funny, she was reading me a section and we were talking through it, and there was a word that was not there that was there during the draft guidance. And I just laughed because I was like, oh, they're clever. And I picked it up. She's a lawyer, but I picked it up because when she was reading to me, I heard it because I heard the difference. And I think I heard the difference because my background's probably more communications. And it was the difference of they had publicly available information and they dropped publicly. So it just said available information. I'm like, oh, they can get it from an email. Somebody sends them an email. And she was like, oh. So, I think that, I think being like just knowing like how to think about how words are used is very helpful. In terms of like being part of health insurance reform, the good thing about being in health policy is all the conversations stay the same. All the problems stay the same. It's just new people are brought into the party. So, there's so many ways to get involved. I would encourage you, if you have any interest, I never worked on the Hill, but if you have any interest, work on the Hill. It's rewarding. You'll learn so much. There's really great people on the Hill. It's like boot camp. Learning the process, learning how the system works, all that is really beneficial. Going into the patient advocacy organizations is a great place to learn as well. There's just so many opportunities here. I would even say, states. Yeah. The states are a great place. So many states are doing a lot of really cool stuff. And I will say this, the states are where they're the incubators. Everything that happens here in DC, it happened in a state before it happened here. ACA is Romney Care.
Yeah.
I mean, it just is. It's just a version of it. But you just look at like what's passing in the states, and then the feds learn from the states, and then they bring it here and they tweak it. But for the most part, the states are where the experiments are happening. And so that's another great place to go and learn, is to go be in a state legislature or go work in a state capitol, go work in state advocacy. But there's so many places, and especially right now, you know, where states are going to have to pick up the mantle and they're going to have to figure out how to solve some of these problems: medical debt, appeals, hospital consolidation, drug prices, healthcare prices. So many issues are on the table. Medicaid,
The work requirements.
work requirements. You know, there's so many problems, and states are going to be the ones that are going to be looking to solve them.
All right, so I'm just going to move from right to left. Anybody? Please.
So I know we talked a lot about negotiating drug pricing, and that's important for obvious reasons, cutting out-of-pocket spending, making healthcare more affordable. But then also in a sense, profitability is what incentivizes these big pharma companies to invest in R&D, right? Because in the long term, that's what's going to drive innovation and more effective drugs. And I can imagine there's this sort of challenge in finding a balance between cutting drug costs, but also, keeping the industry sustainable. And I know Pfizer is getting some leeway on tariffs in return for cutting their drug costs in the States. So I wanted to ask, what are some other ways that are being used to sort of address this challenge?
Yeah, I think the innovation argument is probably the biggest lie that the industry tells you. So one way they can do it is they can stop doing stock buybacks. That's one way. I think that the pharmaceutical industry is probably the most profitable industry in the world, hands down. And if we want to have real innovation, what we could do is make sure that we're funding NIH to the fullest extent, because that's where innovation is coming from. When we see breakthroughs, mRNA technology, NIH. I mentioned Sovaldi earlier, NIH. 98% of the drugs that are on the market, NIH. So, that's where innovation is really coming from. The R&D that the drug companies are doing, by and large, is translational science and extending their life cycles on their existing drugs and doing product hops to keep their monopoly pricing in place. And so, yes, they need to be innovating. They need to be doing that work. They need to be doing R&D. But even the drugs that were negotiated in the first round, if you look at those companies and look what they've been doing, they haven't dropped their R&D spend, even though they've got negotiated and their prices got cut. The drugs that were negotiated, they were on declining revenues because they've been on the market for a while. So they actually some of them actually increased their R&D spending because they need to go find the next product. And so they're saying they're worried about innovation. But if you listen to their shareholder calls, if you look at their SEC filings, that's not the case. So, when you hear arguments like that, dig into it. Great thing about publicly traded companies, they all have SEC filings. They all have shareholder calls. Those transcripts are all public. And I think the thing about the stock buybacks too, tech companies do the same thing. If they're buying back their stocks, that means they're doing pretty well. So that's something else to think through. But, we're seeing some of the most innovative technology coming out of the industry that we've seen. CAR T, cell and gene therapy. I mean, look what happened with baby KJ earlier this summer. We're seeing some really amazing stuff come out. I don't anticipate that's going to change. The other thing with the pharmaceutical industry, I think this will push them to be more innovative. I think if they have to, they will take bigger risk, which means we will have breakthroughs. We will get that next jump in technology. We'll get that next jump in science versus getting, I don't know how many GLP-1s we can have on the market, but there's something like 98 in the pipeline. I don't know that we need 98 GLP-1s, but what's the thing after that? Let's get to the next thing.
All right, let's see.
So
So it's an opportunity to hear about your work to push for prescription drug price negotiations. From your perspective, what's the best way for future health professionals and advocates to keep important initiatives moving, even when politics may make progress slow and difficult?
Don't give up. I think there'll always come a time, and I think being ready, it can get to be disappointing. I mean, I think when Senator Ted Kennedy died, I think we all
Right.
had a moment where we thought it was going to fall apart, but people kept at it.
Especially when we lost the Senate seat.
Yes. Yep. Senator Brown came in, and I think that was, there was some setbacks. We were so close, and then Senator Kennedy passed away, and then Senator Brown took his place, but people just kept at it. I think just kind of remaining optimistic and just continuing to push. And I think the same thing with the Inflation Reduction Act. The Inflation Reduction Act was the Build Back Better Act before that. It was H.R. 3 before that, and people just kept pushing. And the other piece of it is, don't fight amongst yourselves. I see so many times coalitions break down and they turn against each other, or they find their little territories and their little fiefdoms, and they don't work together. And that is when things go wrong. And that's hard. And I think that happens in certain pockets of health policy more than others. But I think when that happens, that's probably when it's the worst. But just keep pushing. At some point in time, lightning will strike.
And just in my own life, and hopefully change doesn't always take this long, but in 1989, we did a bunch of high-profile hearings on prescription drug pricing. And of course, part of our research for that was I realized prescription drug price hearings in the Senate started in the 50s. So there's a long history of it. But in 1990, we were able, there's a big budget bill that was agreed to between Congress and the President. For the first time, the Medicaid program, not Medicaid beneficiaries, but the Medicaid programs got reductions in the cost of outpatient prescription drugs, which for most states, not all, but for most states allowed them to expand the range of drugs, or at least made them more affordable.
Mm-hmm.
So that was like a real win. A small win compared to what happened 35 years later, when you were able to actually negotiate on a part of a large population like Medicare. A lot of work went on over those years to find ways to both expand access. The Part D program was created so that there'd be actually, it's hard. I mean, we're talking about that benefit didn't exist 30 years ago. So there's been progress. I know it may seem long, and it's a bumpy road for sure, but it is different and better in important ways over time.
And there's little wins along the way that don't get as much attention. So, I'm sure you guys had these. There was little things that would get in a reconciliation bill, or in a in a consolidation bill, or that would be just little bitty pieces, and that would keep you motivated to be like, okay, well, we got something, we got this thing. I remember one time there was a Medicaid fix we got, and this was probably 2017, 2016, and I called Richard Frank, who was the former Assistant Secretary for Policy and Evaluation during Obama, and I was like, I'm so excited, we got this in, it passed, and he's like, you and I are the only two excited about this, because we're the only two that know what it is.
Right.
And he was probably right. It was super technical and wonky, but I was thrilled. I was over the moon, because it was something, I think we'd been working on it for 4 years. But every win matters. I mean, not just the big stuff. Every win matters.
Alan?
Thank you again for your time. I was wondering, having worked with the government, both from the public and private side, which job have you learned from more? And taking into account what you've learned from those jobs, what do you think are the greatest threats in the future to access to care?
Definitely learn more in government. I feel like when you are in government, and I've said in different agencies too. I will say that. I think that's part of I've said in different agencies, I've said at different levels within the department. There's always something new. There's always something that I didn't know from before. There's always a loophole that I didn't know about. There's always a office I didn't know existed. There's always a rule I hadn't known about. So I definitely learned more. I think too, just watching how government works is always fascinating. There's a lot of unwritten rules in government. And so being in there, you kind of get to understand them. You get to know like the different cultures of the different agencies and how they work. So definitely government. And I think like the one thing I always stress, like especially when I'm on the outside, and I'm talking to people on the outside, the thing that is probably the most important thing to do when you're working with government is, one, don't assume that people in government don't want to talk to you. People in government do want to talk to people. They desperately want to talk to people. I think the saddest thing that they hear is when people say, well, I don't want to bother you. No, they actually want to talk to people. And then the other thing that I think that I say to people about government is, don't assume people in government know what you know. Because it is a very different experience being in, especially if you're a long-time career person in government, if you're a civil servant. If you're a long-time career civil servant, it's versus somebody who's in maybe private sector, don't assume that you know everything about what the other one knows. Make sure that you're communicating and that you're communicating openly. So I always try to stress that when I'm on both sides, to make sure that you don't take things for granted. If something, even the littlest basic thing, could be really important in a conversation, because you don't want to have something not be said and then have it be misinterpreted or miss a nuanced point that could actually make a big difference in how policy or how an operation ends up being put into place. So, I feel like that's kind of always been my advice on either side, but I've definitely learned more in government. I love government. I think it's a fantastic place to be. I worry about the state of government right now, but I'm hoping that one day I'll be back there doing something, setting up a new program, doing something.
Let's see. Did you have a question?
Yeah. Well, my question is sort of more related to like markets in general. I'm an economics major, so like my grade is but like we've all this the entire time we've sort of just been talking about the fact like there is demand for drugs and how we can sort of make them affordable and stuff. I feel like as we sort of lost focus of the fact that there is a way to manage demand and also artificially or just incentivize supply on the other side. And we sort of stopped talking about those things, especially in Norman, because I was looking stuff up a couple of days ago, and we were spending 24% of the Medicare budget goes towards dialysis, which seems kind of ridiculous. And so I feel a lot of this money, could be used to make Medicare solvent, for example, in the long run. So I'm just sort of curious, what do you think, how we can sort of manage demand and also create supply on the other side, so that we can reduce prices and make stuff more affordable in general?
Yeah. The dialysis piece is probably because when you are diagnosed with end-stage renal disease, you're automatically qualified for Medicare, regardless of how old you are. So that's probably part of that. But, I was lucky enough when I worked in Office of Health Reform that I got asked if I wanted to go to an OECD meeting in Paris on drugs. And I was like, yeah, sure, love to. Fantastic.
You made yourself available.
Yes, I was like, sounds like fun. So I got to go. I represented the United States. I had a colleague from FDA also went with me, and I sat in a meeting for 2 days of people from other countries, basically telling me that Americans were old, fat, and took all the drugs. And paid way too much money for them. And it was fascinating to me because it was very much their perspective of how America, to your point, shifted a market. And, you know, part of that is we're one of 2 countries that allow advertising of drugs. I think this gets back to the direct to consumer sales of drugs. We have a system that manufacturers talk to providers and give providers sometimes incentives to promote certain types of drugs. So yes, I think there could be a lot of things done to balance this out and make sure, but you know, right now the way our system is structured, we cannot do that. And so we would have to make some changes. And with the direct-to-consumer advertising, that's actually a First Amendment issue. It's a constitutional issue here. And so, you know, the Trump administration is trying to work on that right now. They announced a few weeks ago that they were going to start cracking down on some of the advertising to make sure it was accurate and in terms of disclosing all the side effects and potential harms that some of these drugs have. And so they're supposed to be working on that right now. And so some of these ads will be taken off the air. But like I said, it's a constitutional issue, so I anticipate they'll be challenged. But we have a system that actually encourages people to be on prescription drugs. And we have the largest market in the world for prescription drugs too. We spend the most money. So it's a very complicated system. And, you know, I think there is, I mean, this could be a challenge to all of you. I think there is a lot of work that could be done there.
So maybe see if there's anyone online has questions. Do they, Joanna?
So there's a couple of questions online. I'll read the first one. So this question is from Claire. When communities are hearing conflicting information from the highest levels of government, how can communities know who and what to trust?
That's a good question. You know, I would encourage people to, I mean, obviously to do their own research and go to sources that they trust. You know, I think like we were talking earlier, you know, whenever I think about, you know, I hear stories about like, oh, our drug companies like not spending enough on R&D, the first thing I think about going to is like, well, I'm going to see what they're saying to their shareholders, because they're not going to lie to their shareholders because they'll get in trouble. So, you know, I think go to sources that you trust and see what they're saying. You know, another barometer I mentioned before was, what's the stock market doing? How are they reacting? I think that's always a good indication of like, okay, is this good or bad? In terms of for investors. But I think it is really hard right now. And I think it is really hard with social media to kind of decipher what is, you know, accurate information. I also feel like, we were talking about this earlier, when it's incomplete information, that also makes it very difficult, because it makes it harder to figure out what is not known. Is sometimes harder to distinguish than just hearing something that's maybe not true. So I think it's very difficult, but I would encourage people to go to sources you trust and do research.
Got another one?
Yes. So this question is from Jeff. With the backdrop of the Big Beautiful Bill, what broader social impacts are we already seeing in rural areas where hospitals are closing or curtailing services?
I think it's not just hospitals. I think it's also community health centers. I think we're already seeing that, and we were seeing this before the Big Beautiful Bill, so, you know, I think rural health areas have been in trouble for a long time. But, you know, we're already seeing closures of hospitals, in particular certain outpatient centers, you know, so birthing centers, I think, are a big place. I think also specialty care has also been a place where you start to see closures early before the actual hospital closes. So oncology care is one where you'll see that close before you actually see the hospital close. The community health centers consolidating and closing, I think, is a real big one. I mean, I think we saw that in Virginia. A couple of weeks ago, we saw a lot of announcements of some rural community health centers that were consolidating and some were closing. So I think that it's going to be, you're just going to see this trend of the footprints are going to get smaller, but and to the point where it won't be an all of a sudden they're gone, but you'll just start to see them slowly closing services and offering fewer and fewer services. I think the other thing to keep an eye on too, and in addition to hospitals and the community health centers, is independent pharmacies in rural areas where there aren't the Walgreens, where there aren't the CVS's, the Rite Aids. Sometimes independent pharmacies are what is available. If there's not providers in those areas writing prescriptions, then that also puts the pharmacies at risk too. And so that's another barometer of like, if they start, they're really struggling as well. They've been struggling for a while, but if you're going to start to, I think, see more of them close as well.
So, did we get them all? Or,
One more.
I'm sorry, have I missed anybody? Oh, I'm sorry.
Can I go after?
Sure.
That's fine. Thank
Okay,
you.
okay, I'm sorry. I didn't see you over this.
This question is from Anonymous. So what equity concerns do you see emerging around access to drugs like Ozempic, especially given its limited insurance coverage?
So I think the GLP-1s, I think there's several of them on the market now. They're getting more and more indications. I actually think the more indications they're getting, the more complicated it's going to get. Because I think as they get more indications, then you'll have more utilization management practices put on them, whether it's step therapy, prior authorization. Because then I think insurance companies will be like, well, what are you using it for? Are you using it for cardiovascular risk? Are you using it for weight loss? Are you using it for diabetes? Are you using it for sleep apnea? And more studies are coming out. You're seeing studies for, does it have an effect on menopause symptoms? Does it have an effect on, sleep apnea was one that they've been working on, but substance use disorder, many.
Yeah.
And they don't even know how they work. They just know that they work. And so, I think there's always going to be equity issues around them. I don't think that that's going to go away anytime soon. Some of it's because of the price. They are very, very expensive, and they're just not as expensive in the rest of the world. And so and the funny part about it is there's quite a few of them on the market right now. It's interesting you're not seeing brand-to-brand competition start to bring down the price. There's quite a few in the pipeline. I mentioned the Hep C stuff earlier. When the fourth Hep C product came onto the market, the fourth Hep C cure, Obscura, when you saw them come onto the market, they started competing against each other in price, and you saw the price drop. But it's not happening here.
I was going to ask you, why do you think that is? Because it does seem like those are big companies with well-known names. I mean,
I think it's because it's in their interest to keep the price high. And, the FTC has done a number of investigations on price collusion on other products. They've done an investigation on these companies on price collusion on other products. And so, I think it's interesting we haven't started to see the price go down with brand-to-brand competition. But I think until the price goes down, we're going to have problems, because you're just going to have more people who are going to be, as the label expands with more indications, more people are going to be eligible for these drugs, and we just don't have an answer until there's a lower price.
We'll give you the last word.
Thank you so much. So my question ties back to drug advertising in the U.S. So I'm a nursing major, and in nursing we focus a lot of our discussions on patient-centered care, and giving patients the information to make health decisions that are in their best interest. So do you think that drug advertising empowers individuals in making choices, or do you think that the American public's general health literacy is not in place that allows for this? And is there too big of a gap between the pharmaceutical industry and consumers to allow for this autonomy?
My husband is Pakistani, and he has lived in the U.S. off and on since 2015. And it's funny to hear him comment on things that strike him in the U.S. One is Medicare ads, Medicare Advantage ads. He's like, what is going on with this? He thinks they should be illegal. The second is campaign ads. He doesn't understand those. And the third is drug ads, because in Pakistan they don't have them. And his impression is every time he sees them, he's like, well, we should just get that. And I think that's telling for a 40-something-year-old man who has 2 graduate degrees to say every time he sees a pharmaceutical ad to be like, oh, we should get that. And I'm like, no, we should not get that. But I think that kind of tells you, like, they are made to be, one, catchy. I mean, how many people can sing a jingle from one of the pharmaceutical ads? I'm sure all of you can, at least one. You know, they're meant to be attention grabbing. You know, they have catchy names. You know, they're meant to sell a drug. So I have a lot of mixed feelings about them. You know, I do think that they can help people who, you know, there is the disease awareness ads that I think are helpful. You know, like there's the ones where you have the things that maybe people are not as well known about, that where people are like, oh, I do have those symptoms, so I should talk to my doctor about that. You know, when they were doing a lot of the work around Hep C, you know, they had the ads about Hep C and like, do you have hepatitis C? There could be a cure for you. Go talk to your doctor about it. I think those ads could be helpful, where you're trying to educate people about there could be a treatment for them. Go talk to your doctor about what your treatment options could be. But the ads where they're like really selling hard the drug, I think it's hard sometimes for patients to distinguish the difference between they're selling you a drug and I need to go talk to my doctor about a health condition I have to see if that drug's the right drug for me. I think that can be difficult sometimes.
It's probably as good a place as any to end. But I want to ask everybody to join me in a round of applause. Thanking you.